All right, so basically we're talking about anesthesia complications. And complications essentially are inevitable. They're going to happen to everybody, even if you try to practice perfectly. And I just threw this picture up. Just any professional is going to come across it at some point in their career. The biggest thing is preventable versus unpreventable mishaps. And as much as I hate the analogy when I was training of this is just like the airline industry, you know, we have all these preventative things. It actually does come to play true in anesthesia. The more prepared you are, the easier it is to prevent mishaps. And so that's a big key. Unfortunately, still, human error is the most often the cause of preventable mistakes. We like to blame the anesthesia machine, the tech, the nurse in the room that didn't get this drug or that drug, but it's really human error that comes into play. So how often do we have bad outcomes or anesthesia complications? It's pretty hard to determine because we're not all honest, or it's hard to kind of report things that are not necessarily bad outcomes but are something that didn't go right, basically. But perioperative mortality is pretty clearly defined as death within 48 hours of surgery. Mortality rate in the past used to be pretty high. It was pretty dangerous going under anesthesia. Your death rate could be anywhere from, some studies quoted 3 to 5 per 100,000, and now with better technology, better surgeons, drugs, and knowledge of what we're doing, it's down to 1 in 100,000, which is pretty good. If any of you are familiar with the ASA Closed Claims Project, what it is, it's an attempt to kind of show the liability and the complications that can happen in anesthesia. The problem is this is a self-reporting system. Nobody's held accountable. So when you get sued for, say, a chipped tooth and you settle that lawsuit, that can get put into the closed claim. So you obviously have to be honest about the mistake. You have to address it, and then it can be put into this database. And if there's only 6,700 claims from 1970 to 2000, you know that not everything's being reported, but that's about the best thing that we have besides our M&M, morbidity and mortality in each respective hospital. But the whole goal of this is to identify major areas of loss and then to take those areas and figure out what happened in those cases, and not to point blame, but just to see where we can make improvements in our care. It's just a snapshot. It's not a true determination of liability and or kind of exactly what went wrong, but can kind of guide us into maybe doing some studies to figure out exactly what went wrong. Most studies show that most of the problems are preventable or were near misses. Basically, a preventable accident is not synonymous with incompetence. Most of the stuff that actually happens, most often, at least about 80% of the time, is meeting the standard of care. The top claims, and I think the last time the ASA closed claims was examined, they're allowed to like go in and look at all the data, was in 2007 and then 2010 were the two times I took a look again. But the top claim, the most robust data recently we have is from the 1990s, and it said that death was the top claim at 22%, nerve injury, and then brain damage. Death and permanent nerve injury were equally associated with cardiovascular events and respiratory events. In the past, that wasn't the case. We had a lot more issues with respiratory events, and that was before the invention of end-tidal CO2 and pulse oximetry. In addition, we also now have algorithms for airway management that have greatly increased our success and decreased the amount of esophageal intubations. Roughly 64% of respiratory-related events were due to substandard care, though. So when we are having trouble with the airway, we're screwing around and not doing what we should be doing. And only 28% of those for cardiovascular demise. So again, when you're a cowboy and you know you should be using a glide scope or a fiber optic and you're not, that's where you're going to get into trouble and you kind of fall into this category. What the recent most ASA closed claims did, they looked at sections of anesthesia care like vascular cannulation, pediatrics, and regional more so. Before they were just kind of looking at it all together. But there was 47% of claims that were for central vein access were for death. And that represented almost 2% of all claims total, which I think sounds pretty high. I've not had someone die from a central line placement in my mind, but 2% is pretty high. But of the claims that are in there, that's what the numbers are. In 2004, they did an analysis to kind of see what we could do differently. And the most independent factor they found was whenever lines are repositioned or a line is placed, it's just to do a chest x-ray, which we all don't do in anesthesia. So that was the recommendation. But then they had a secondary recommendation. They basically just said use multiple ways to figure out that your line is in place. So ultrasound machine, you can connect tubing and watch for the column to drop. All the stuff that we do when we put a central line in, they said the more things you do to check it out is going to help prevent complications, which makes common sense. Surprisingly, 2% of claims were due to peripheral IV placement, and if you think about all the cases we do where we wrap the patients up pretty tight, you can get extravasation of fluid pretty easily in a lot of the rooms that we're in, mostly like the ENT and the cardiac cases where they wrap the patients really tight and lean on them the whole case. So OB, that's a scary place for many people to be. Out of 5,900 deaths, how did I read that? So this pregnancy mortality surveillance system, that was just some scanning of the data. 86 were thought to be due to anesthesia, so 86 out of 6,000 deaths roughly. And that was about 1.6% pregnancy-related deaths out of all the deaths in the close claim. So 2% for vascular cannulation die and 2% for OB. It kind of didn't make sense, but that was what the number said. The decline in anesthesia-related deaths most recently has been due to a number of things. We're using general less often, using reduced concentrations of Marcaine, and we have better airway management. We have the glide scope, we have algorithms, and we also use incremental dosing of epidurals rather than just giving them a 20 ml slug of lidocaine and hoping they do well and don't get a high spinal. So those are basically the improvements. From 1990 to 2003, there were 426 claims compared with 190 claims in the database prior to 1990. So what that tells me is that people are having trouble more often, or we're just having a more litigious society right now. The good part was, though, the claims for maternal fetal demise were lower. So we're getting basically sued for non-death issues, basically other things. The most increased area was maternal nerve injury, which they didn't specify which injury, but they're obviously could be in the lithotomy position, and sometimes it could just be flat, and then they have their arms spread out, so it could be upper extremity injuries. They did include both neuroaxial and other nerve injuries, but they didn't differentiate between the two. The one thing they did recommend after looking at all the data was that the most important thing is that most injuries cannot be discerned by an anesthesiologist or an obstetrician immediately, and sometimes nerve injuries take about 48 hours to develop. Early neurologic consultation is the best way to keep you from having issues, so you can determine was it positioning from the surgeon or was it your nerve block or your neuroaxial that you gave. That make sense? Regional anesthesia. So there was 159 of 6,800 claims that were analyzed most recently. 8% were resulted in death, 36% were permanent injuries, and 56% were just temporary injuries. The brachial plexus was the most common nerve injured. Nerve injuries constitute the third most common source of anesthesia litigation. And as Dr. Alpert would say, that's why he does not do any regional anesthesia, something like that. But no, there's plenty of anesthesia attendings that would say that. Retrospective review also looked at perioperative nerve injury as like 0.03%. That was just another study that examined data outside the ASA close claim. I thought, interesting enough, risk factors were hypertension, diabetes, and smoking increased the risk of nerve injury in and of itself, and they cannot determine a cause why. And also interesting to me is rarely is care associated with ulnar nerve injury judged to be substandard. It's the most common nerve injured for us. We do a good job of padding the ulnar nerve and making sure that we don't have an injury, but it's the most common still, and it's usually not due to anything that we do. Pediatric anesthesia. So the 2007 study reviewed 532 claims in patients less than 16 years old, and that was almost 30 years of data. So again, 30 years, and all they have is 530 cases of problems, so it's not well reported. Most of them were for death and brain damage. Cardiovascular events joined respiratory complications, sharing primary cause of pediatric anesthesia litigation. So classically, kids arrest because of respiratory issues versus adults who usually arrest because of cardiac issues. So what they found here, we had decreased arrests due to cardiac because we have better monitoring. We were catching things earlier with mask inductions. For the students that haven't done pediatric cases, you mask induce without an IV. They get all this gas on board. We used to use halothane, and your MAC equivalents basically would build up. So you get deeper in anesthesia, and then all of a sudden the heart stops working. With sevoflurane and some of our better techniques, we're now able to catch that earlier. So we've had less cardiovascular deaths, but they've just kind of evened off with respiratory events, which usually come with postoperative care. So there's a thing in pediatric anesthesia because there's a lack of reporting, so all the children's hospitals got together and said we need to actually figure out why kids are dying, and it's called the POCA, the Pediatric Perioperative Cardiac Arrest Registry. and they collect information from 80 institutions, and usually most of the pretty good institutions participate in this. And we actually just started this with Dr. Redding, starting to give some of our information. There was 193 arrests reported between 98 and 2004. About 20% of those were drug-related compared to 37% of all arrests between 1994 and 1997. So again, I think we're just catching things early before they deteriorate into arrest. Cardiovascular arrests were still the most common out of all arrests, and they were most likely due to hypovolemia and hyperkalemia. Respiratory arrests were 27% and due most often to laryngospasm. One issue that you guys will come across once you get done with your training is post-operative care. You do this kind of fake rotation for a month of PACU care, which is a good opening interview to it, but afterwards the PACU becomes more important than a lot of other things because you're starting to see these complications come out. And one thing that we've had problems here with is keeping kids for a certain amount of time, and most of the respiratory arrests that we have happened out of the OR. Not at this institution, but across the board. So it's laryngospasm happening in the recovery room or on transport to the recovery room. That's pretty scary because that's where we're probably least equipped to handle those problems. So just a point that when you get done, you're going to experience more of this. All right, moving on. ASA closed claims also looked at machine problems. I have yet to have a machine problem, but I have heard of people having their oxygen go and other related things here in the past 2 or 3 years. Equipment misuse is 3 times more common than actually the machine malfunctioning. So basically, we don't do a proper machine checkout. We don't have proper pressure in the system, and it's really we didn't do a good checkout, and it's not the machine failing. Most importantly, when you have machine failures, it can cause death pretty quickly. 76% of adverse outcomes resulted in death or basically permanent brain damage. Of the closed claims, they said 4% of claims came from adverse drug reactions or drug errors. Some hospital studies say drug errors happen 20% of the time that any medicine is given. I find that very high, but that might be the case. And most of them are due to incorrect dose or syringe swaps. So common human errors, unrecognized breathing, circuit disconnection, mistaken drug administration, airway mismanagement, anesthesia machine misuse, fluid mismanagement, IV line disconnection. These are probably all things that you've either seen or just seem very apparent, but they happen daily. The biggest thing with anesthesia, I think, and the complications that occur is not that those things happen. It's you recognize it and then you take the proper steps afterwards to kind of take care of the problem, make sure it doesn't cascade into a snowball effect. So there's 2 types of errors or kind of ways to look at this. A fixation error is basically you're sitting there ignoring a critical problem because you're fixated on, say, let's just say PISIS, the computer screen. Or in young training, you're worried about the A-line and you're not watching your ventilator. You can make up a million scenarios. But this is a pretty big error, I think, when you're first getting training and everything is just so overwhelming. A lot of noise, you got to deal with the surgeon, you got to deal with your attending telling you what to do. And you get distracted and focused on one thing, and then all of a sudden a problem comes and you're doing an incorrect solution to that problem too. And I forget the quote. If anybody knows, they can tell me. It basically said that any sentinel event in a hospital has 4 or 5 mistakes made prior to that sentinel event. Does anybody know what I'm talking about? There's some kind of quote that, those little things we get daily from Danielle Schur. That's the type of statement. And it's been proven in studies that it takes like 4 or 5 mistakes before you have a sentinel event. And that's pretty true in anesthesia. And it could be coincidental, it could be misjudgments or technical errors, but if you add them all up, there was probably 3 or 4 points along the way that you could have stopped what was about to happen. So these are all, you guys know all this, but some things are inadequate prep, like you don't check your machine out, or you didn't check for the pre-op and didn't know the patient had myasthenia gravis. Inadequate experience, or you're unfamiliar with the technique, so you go to your neuro rotation. Day 1, you have some rough craniotomies. Environmental limitations, you can't see, you have a surgeon who doesn't communicate, that can just make for a rough afternoon. Physical, emotional factors, you're just having a bad day, you're tired from last night or the new late shift that they've created that you guys have been not having to stay late for. This is an outdated chart. This was from last year, but they had more data, but this is just kind of a list of all the different complications and the relative percentage that they made up. So and that's another, awareness being 2% is interesting because death from central lines is still 2%, which baffles me why it's that high. One of the most common injuries is airway injury, is dental trauma. The incidence is about 1 in 4,500 patients. Risk factors that are obvious are direct laryngoscopy and endotracheal tube placement, most often involved the incisors being injured. And risk factors are obviously poor teeth, difficult airway, and direct laryngoscopy. So pretty straightforward. There are a couple different types of airway trauma. And out of the closed claims, remember there was about 6,000 cases. They only had 266 claims. Some are TMJ injuries, where basically people got lockjaw, or you pop their jaw out of the socket, basically. And you have laryngeal injuries, vocal cord paralysis, granulomas, arytenoid dislocation. We see a lot of laryngeal injuries in kids being intubated with either too big of tubes or lack of sedation after the tube stays in the ICU. So that's pretty common in pediatric patients. Most tracheal injuries are due to emergent tracheotomy and not actually us doing intubation. And esophageal perforation is kind of one of those things that, kind of like MH, you hope it never happens, but if it does happen, you're in a lot of trouble because the risk of death is so high. And then another one is pharyngeal esophageal perforation, which is even trickier because it's a delayed onset where you have the perf, you don't recognize it, you do the case, and then postoperatively the patient develops the symptoms that are up there: sore throat, cervical pain, cough, and they progress to fever, pneumonia, abscess. Obviously, people with more friable tissues, a little bit older patients, or difficult intubations lead to help set you up for this complication. But that said, it's pretty rare, but when it does happen, it can be pretty complicated. So how do you minimize the risk of airway trauma? The things we do every day: good thorough airway exam, document dentition, and discuss with the patients. I go back and forth about how much I should discuss. I might knock out a tooth. I think it goes by the state you practice in. We're covered pretty good with the state here. I don't want to scare every patient that I'm going to knock their teeth out, so I probably wouldn't talk about it. But if I was in private practice in a private hospital, I would probably mention a couple of these more often. Here, our population, too, doesn't tend to have great dentition to begin with. So usually I just mention, and that's not being critical, I think I mention it more when I think that there's a high likelihood of it being knocked out. So I think you can kind of select how many of these things you should tell. Because the way Morgan and McHale tells you, you should tell everyone that you're going to knock a tooth out. You might perforate their trachea, and we know from the data that that's not knocking a tooth out is common, but some of these other things are not worth mentioning necessarily. You can go back and forth. Biggest thing, too, is have difficult airway equipment available and have your ASA algorithm in the back of your head at all times, which is right there. Let's move on. So perioperative nerve injury happens both with regional and general anesthesia, and that's where the ulnar nerve kind of came in. It didn't matter if you had regional for the ulnar nerve to be hurt. Peripheral nerve injuries are more common than spinal cord or spinal root injuries. They often can be debilitating. Luckily, they'll most resolve in about 6 to 12 weeks, but many can last years to months, or months to years, excuse me. So of the nerve injuries that were in the ASA closed claims, 670 of them were for anesthesia-related injuries. Most frequent sites were, again, ulnar nerve at 28%, the brachial plexus at 20%, and then the other ones, the spinal cord and the nerve root at 16 and 13%. So again, ulnar nerve injuries occurred under GA 85% of the time. Spinal cord happened 58% of the time with regional, so you're still having spinal cord injuries probably from lack of perfusion in the other general cases. And of note, the ulnar nerve injury is more common in men and frequently delayed in onset most of the time. So that's where that neurologic consult comes into play, of figuring out when the nerve injury actually happened, because it will be delayed most likely. So all the nerve palsies, and there's a chart in Morgan McHale you guys can look at, but I'll go through this pretty quickly. So brachial plexus, you're avoiding stretching or compressing your axilla, whether you have the arms up in the air or extended out on the arm boards. The common peroneal nerve, you want to pad the lateral aspect of the fibula when you're in lithotomy position, or basically any time the leg is exposed and you have somebody leaning on it or they're in stirrups in lithotomy. The radial, you want to avoid compression of the lateral part of the humerus. The ulnar nerve, which we're all good at, we just pad the elbow and the forearm, and you want the hands in the supinating position, not the pronation. Other positioning complications, which I think most of the time we're experiencing these in some of the neural rooms. We don't do sitting cranies anymore, but we do a lot of robot cases where you're tipped in steep Trendelenburg, or you're head up in other neural rooms where you can get an air embolism. So basically, you're trying to keep the venous pressure above zero at the wound site. So when you have veins open and you have negative pressure because of hypovolemia, it can cause a sucking mechanism that can pull air into the veins, and that's where an air embolism occurs. You can get air embolisms from a variety of sources, but the ones that are usually, chaotic and horrible are the big ones when you have a lack of venous pressure, and that's usually in the sitting cranie position, and a couple different, if you hit one of the big vessels when you're doing a central line, and they're not with the head down. The other injuries that are common are alopecia, which happens a lot in heart rooms because the poor perfusion state and the head's not padded correctly. But it does happen in even normal intensive rooms. Compartment syndrome, where basically, we're trying to maintain perfusion pressure, avoid external compression too. Skin necrosis, so everything's padded, everything's nice and soft on the beds. We have new head donuts and all that usual stuff that we do to protect people's body parts. Positioning complications also include eyes, so corneal abrasions and retinal ischemia. So normal tensive and don't put pressure on the globe. All kind of common sense things that we talk about every day. So awareness, something that doesn't happen all too often but is talked about a lot. And most accounts of recall aren't really recall and awareness, but certain patterns are pretty clear. The incidence is anywhere from 0.2% to 0.4% of all general anesthetics. Major trauma, cardiac cases, and OB cases with many comorbidities are usually the most frequently associated with awareness. Anybody see this movie Awake? I didn't watch it. It looked horrible. But I think this is when I was in training, and it was a huge deal because ASA actually came out with a pamphlet of how to address this because you knew you were going to have patients walking in saying, I saw this movie doc. And in Rush in Chicago, we actually had the pamphlets of how to handle the patient. Well, because you're not going to get into a 20-minute talk in that setting. So this was interesting when it came out. But back before the most recent closed claims, I look at closed claims from about 2003 back, and there were 79 claims of awareness, which equaled 1.9% out of that 4,000. 18 claims were for awake paralysis. The majority were for recall under anesthesia, though. Women were most commonly to have awareness. Most were younger than 6 years old. Most were elective surgeries, and they were relatively healthy patients. Interesting enough, the substandard care portion were most often awake paralysis. So that's probably where the syringe swap comes. Grab the red syringe that you thought was this, and you push vecuronium, and you didn't realize the patient was paralyzed for a long time. I think that's probably cut down a little bit with some of our new drug protocols and pre-drawn-up syringes. And again, only 43% of recall were deemed to be substandard in care overall. So like I just said, the closed claim said that basically labeling and lack of vigilance was for the awake paralysis. Again, and then they looked at it this most recently with another 71 claims added, and the claims for recall were, again, kind of backed up what we said earlier, women and some of the other surgeries like cardiac surgery or OB surgery that had a high risk, and also those that had a nitrous narcotic technique, which is pretty much not used much anymore, but was used years ago. Two interesting parts that actually I know daily I argue with residents or CRNAs is about, well, not the substance abuse, but long-term substance abuse. If you don't know if somebody's drinking a case of beer a day, you don't know that they're going to tear through their drugs. So that was one subset that they found, that people that claim they had awareness. But randomized controlled trials do not show the biz to be worth anything. I think we erroneously place it on to give us a little safety net, and it's really supposed to be used just for wake-up in the ambulatory setting. But often I hear that I'm going to put this on because we're worried about the patient being aware, or we don't want a low blood pressure, we want to run as low of anesthetic as possible. But all randomized controlled studies have not shown a difference with the biz. So that's a device that's sold and marketed to do this, but it's not been proven to actually work. Question? The biz, the bispectral index. So have you seen the little monitors that go on the forehead? Yeah. So my other lecture actually has the explanation of it. So what it does is, just like an EEG, it has algorithms of basically where you need to have a patient, and the numbers go all the way down to 0 to 100 or 80, where you want people in a general range of numbers, and can kind of tell you that you're deep enough under anesthesia. But that said, it doesn't tell you you're deep enough because it hasn't been proven to do so. What it does tell you, though, is the scales. You're not tipped to where you have no brain activity. So if you put a biz on somebody and push a full syringe of propofol, it's going to go down to like the teens or 20s. where they hope to market it as it would keep you in a range of very light anesthesia to wake up faster. And we kind of hybridized it and used it to keep people from being aware. Does that make sense? So you might as well just put a piece of tape on the person's forehead and cross your fingers as far as I'm concerned. Because there's evidence, but how many of you, raise your hand if you put a biz on somebody because you're worried about awareness. There you go, half the group. So, and I don't think that's wrong. You can do whatever you want if it makes you feel better. But again, we haven't had studies that show that it actually works. Do attendings tell you to do that too? Okay. I'll have them come to my lecture next time and see if I can talk them out of it. Yeah. Yeah, so